This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1014, recorded on June 8th, 2023. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
How's the air quality out there, Daniel?
You know, that's been the topic of conversation. It was horrendous yesterday, but I've been trying to get some kind of a sense, right? You know, so today it's about half as horrendous as it was yesterday.
Yeah.
My eyes have been tearing up, and I'm trying to figure out. We need a this week in just random things where we can ask someone, because they're like, it's really bad, but it's really bad. Like, is it like if I spent 2 hours out sailing? Is it like I smoked a cigar or half a cigarette? Or I'd love some sort of quantification. But
good question. It's out of my lane, Daniel.
It's not in mine either. So, all right, let's hey, email us please, because I'd love to be able to give some context here. Today, I am wearing my HIV bow tie, and I will start right with my quotation. Being honest may not get you a lot of friends, but it'll always get you the right ones. And that's by John Lennon. All right. I will jump right into COVID. We start with the MMWR estimates of SARS-CoV-2, seroprevalence, and incidence of primary SARS-CoV-2 infections among blood donors by COVID-19 vaccination status United States, April 2021 through September 2022. Just came out June 2nd. Now, to estimate the incidence of infection and prevalence of infection or vaccination-induced antibodies, or both, data from a nationwide longitudinal cohort of blood donors was analyzed. A lot of people have comments about how representative are those of everyone else. CDC, in collaboration with Vaccination, American Red Cross, Creative Testing Solutions, and Westat established a nationwide cohort of 142,758 blood donors in July 2021. The cohort included persons who had donated blood 2 or more times in the preceding year. All blood donations collected during April through June of 2021 were tested for antibodies against the spike and nucleocapsid proteins. By the third quarter of 2022, so July through September, 96.4% had SARS-CoV-2 antibodies from previous infection or vaccination. They try to make some comments about hybrid immunity, but they're using anti-nucleocapsid antibody assays, and we've discussed they have sensitivity issues in those previously vaccinated. I think there's a couple sort of interesting things here. This is consistent with the idea that at this point, almost everyone has some form of immunity. The other take could be is that, well, this is just when you go for the blood donations there, you're all crowded in there together. I don't think that's what's going on. I just want to, just shine a light on that. But no, I think it's consistent with the concept that at least here in the U.S., there's a lot of immunity out there as our background. All right. And by the way, everyone should be a blood donor. So this should be representative of everyone. So, okay. All right. Children, COVID, and other vulnerable populations. The article, you're going to like this one, Vincent. I don't know if you read this ahead of time, but the article, Smart Thermometer-Based Participatory Surveillance to Discern the Role of Children in Household Viral Transmission During the COVID-19 Pandemic, was published in JAMA Network Open. And I shared this article yesterday with our urgent care doctors, and there were a lot of chuckles about, how these we allow these walking petri dishes to go out there in the world, and then we let them back into our homes. Mm-hmm. Early on, there was this concept that children could not catch or transmit SARS-CoV-2. You didn't have to worry. Well, in this publication, we read that at a time when the relative rate of viral illness attributable to COVID-19 was at a high, these investigators were able to take advantage of participatory surveillance methods to gain insight into transmission dynamics among 1.4 million individuals in over 800,000 households using commercially available shared thermometers and a smartphone app. See, that was the problem, the shared thermometers. Now, their findings suggest that children play an important role in within household viral transmission. So lots of limitations here regarding the precision of these numbers. So I would not hang any of my hats on any specific numbers, but they report that among 38,787 transmissions in 166,170 households with adults and children, a median 70.4% had a pediatric index case. These proportions fluctuated down 36.9, getting all the way up to about 85%. There actually were some timing issues. A pediatric index case was less frequent during the typical school breaks. And then they saw the winter break decrease was from 68.4%, dropped down to 42%. At the beginning of 2022, it dropped from 80 to 54.5. During summer breaks, the rates dropped from about 81% down to 63. And then they talk about these patterns persisting over 2 years. So what do you think? Is it possible, Vincent, that children go out in the world, get respiratory infections and spread them to others in the household? Have you ever had such an experience?
Yes. Well, of course, that happens with many other infections like rotaviruses and other respiratory viruses. We know this. But I have two questions for you, Daniel. First,
yes.
So they're diagnosing it based on temperature, correct? Is that something you would agree with?
So there are a lot of limitations here, right? And one of I'm going to give you that, and one of the things they're sort of trying to say here is, boy, this was the only game in town. This was a time when almost all these infections, there wasn't much flu, there wasn't much other stuff. That's a bit of a limitation. Okay. You're also probably talking about a select part of our society, right? Folks that have this smart thermometer, smartphone technology, that they're, when we had children, I banned all temperature measuring devices from the home. I felt that made my wife much more relaxed.
Yeah. The other thing is, it would have been nice to do this in households without children to see how the numbers compare, right?
Yeah. Yeah.
Because they're doing the summer drop as indicators that, the kids are not going to school anymore, but it could be something else, right? So it would be nice to know if that happened in households without kids. Yeah.
Yeah. And I think early on, there was also this concern that when the kids were not in school, kids socialize. So, you're getting your kids together with other kids and other people's homes and, of all these discussions.
By the way, Daniel, you have a little note here on masks. You say, remember, masks only work if they're worn. I've never seen people jump to masking when the air got bad yesterday. Isn't that amazing?
It was, I called it reverse masking, right? So people were putting on the masks when they went outside. And as soon as they got to the safety of the air conditioned indoors, off would come the N95s.
Right.
Yeah, I must admit, I went for a run today with an N95, and I'm just not as fit as I wish I was.
But it was so hard to get people to wear masks for COVID. But here, they can see the air is yellow. Sure, I'm wearing a mask.
Yeah, well, that's actually a challenge that my wife brought up. Yesterday it was obvious, right? I felt like I was in, a retake of the Blade Runner, and and so when it's so visible, but that's the problem with these viruses, right? They're invisible. Like if you saw like a yellow COVID haze, boom, the mask might pop right on. So in the future, if we can make viruses just a little bit bigger, a little more visible in the air, that would be helpful. So
maybe we should saturate the air with a dye that will stain viruses. How's that?
This is like the purple stuff in the swimming pool. Like when people come over, you're like, don't pee in a swimming pool because we got that purple dye, right? So yes.
Yes, exactly right.
All right. All right. Look, moving on to COVID active vaccination. I think we have a few interesting things here this week, and I'm going to be continuing this theme next week. Not this first theme. The first theme is no more J&J shots in the U.S. So on May 22nd, 2023, so that was just a couple weeks ago here, Janssen Biotech requested the voluntary withdrawal of the EUA of the Janssen, the J&J COVID-19 vaccine. They informed the FDA that the last lots of the vaccine purchased by the U.S. government had expired. There was no demand for new lots, and they did not intend to update the strain composition of the vaccine. And on June 1st, 2023, so just about a week ago, the FDA revoked the EUA. So that's the end of the J&J vaccine here in the States. So J&J won and done, I guess. We also have news on COVID-19 vaccine mandates. We're also going away here. So for some background, on November 5th, 2021, CMS issued the interim final rule Medicare and Medicaid programs omnibus COVID-19 healthcare staff vaccination, otherwise known as the staff vaccination IFC, which revised the requirements that most Medicare and Medicaid certified providers and suppliers must meet to participate in the programs, to include requirements regarding development and implementation of policies and procedures to ensure COVID-19 vaccination of staff. Now, June 6th, the omnibus COVID-19 healthcare staff vaccination interim final rule, there are lots of finals here, rescinds the requirement for workers and contractors at Medicare and Medicaid certified facilities to be fully vaccinated against COVID-19. This takes effect 60 days after that June 6th publication date. So it's going to expire August 4th, 2023. And in this publication, we can read that, and I'll just read this, as conditions and circumstances of the COVID-19 public health emergency have evolved, so too has CMS's response. At this point in time, we believe that the risks targeted by the staff vaccination IFC have been largely addressed, so we are now aligning our approach with those for other infectious diseases, specifically influenza. Accordingly, CMS intends to encourage ongoing COVID-19 vaccination through its quality reporting and value-based incentive programs in the near future. All right. The article, Changing Severity and Epidemiology of Adults Hospitalized with Coronavirus Disease 2019, COVID-19, United States after introduction of COVID-19 vaccines, March 2021, August 2022. I like that the title here is Changing Severity, associated with the introduction of vaccines. Because so many people like to say, boy, we introduced the vaccines, but what really happened is the variants. So this article published in CAD, of which I love the title. So as I said, and I'm going to say this again, this is, redundancy. Apparently that's a good thing to do. So much time has been spent on making claims of how different the virus was at different times during the pandemic. But I do want to point out this whole time we were building up immunity, mainly through massive, robust vaccination campaigns here in the US. If we were not seeing milder infections after vaccination, then this would have been a fail. So why was the story not all about how effective vaccinations were in reducing the risk of severe disease? I'm not sure there's much new here, but we do read that compared to adults hospitalized during early COVID-19 variant periods, those hospitalized during Omicron variant COVID-19 were older, had multiple comorbidities, and less likely to experience severe respiratory disease, systemic inflammation, coagulopathy, and death. As impressive as our immune system might be when we are young and healthy, we still are vulnerable when we are older. Now, what makes Omicron mild? Having an educated immune system, ideally from vaccination, early treatment with something, well, we'll talk about those some things a little bit later on, and yes, avoiding harmful things like steroids, antibiotics. Okay. And the last little bit here on the vaccine news front, we're going to have some exciting stuff in about a week. We also heard news that Novavax is already producing an updated XBB vaccine version of its protein-based vaccine option that will be ready for the fall.
Yeah, next Thursday is the ACIP, is that right?
It's the FDA meeting.
Oh, VRBPAC is the FDA.
The VRBPAC, yeah.
They're going to pick the SARS-CoV-2 strain, right?
Yeah, I'm going to have to try to figure out how do I jump on right afterwards with updated information and then still, keep my day job. So, all right, we're moving into you have tested positive. Your patient has tested positive. Number one, Paxlovid now licensed. And I have to say, we really have a lot to overcome with the misinformation about the importance of jumping in here early with effective treatment. A person has a raspy voice, a bit of the sniffles, quote unquote, the common cold. And next thing they're on some ineffective antibiotic that is disrupting their microbiome, pushing us further down the road to the antimicrobial apocalypse. But what about COVID? The docs seem a little bit reticent, patients seem a little bit reticent to take something that's actually effective. So the article, Effectiveness of COVID-19 Treatment with Nirmatrelvir, Ritonavir, or Molnupiravir among U.S. veterans, target trial emulation studies with 1 month and 6 month outcomes were published in Annals of Internal Medicine on June 6th. So the good old VA folks again. So for some context, with those of you who haven't been here, the Veterans Health Administration, operated by the U.S. Department of Veterans Affairs, is the largest integrated healthcare system in the United States, providing care to more than 9 million veterans, the majority of whom are older and have a high burden of underlying medical conditions. So lots of high-risk folks. And the VA has provided an opportunity for multiple target trial emulation studies of the comparative effectiveness of COVID-19 pharmacotherapies and vaccines. Here, the investigators used target trial emulation principles to emulate 3 trials of Paxlovid versus no treatment, Molnupiravir versus no treatment, and Paxlovid versus Molnupiravir during the Omicron era. They evaluated, as they mentioned in the title, 30-day and 6-month incidence of hospitalization and death among non-hospitalized adult veterans who were infected with SARS-CoV-2 and were at high risk for progression to severe COVID-19. All right, so 87% of participants were male, median age was 66, 18% were unvaccinated, right? So this 82%, this is mainly unvaccinated individuals. Now, compared with matched untreated control participants, those treated with Paxlovid had a lower 30-day risk for hospitalization. We see a 22 versus 30 per 1,000 participants. And death, we see 1.25 versus 5.47. Among persons alive at 31 days, reductions were seen in 31 to 180-day incidence of death. The hazard ratio there was 0.66. So I like to point that out. We've really focused a lot when we talk about case fatality rates on what happens in those first 28, maybe 31 days. But there's a second chunk of people, and it is a chunk of people that will die after that 31 days, will die in the 6 months after that acute infection. So I'm glad we're seeing data on that. Now, Molnupiravir treated participants also had lower 30-day and 31 to 100-day risks for death. And they give some numbers there. And then the hazard ratio for death in that 31 to 180 days was 0.67. So very similar. So about a 33% reduction in that second zone of death. So just to wrap this up for folks, Paxlovid was effective in reducing 30-day hospitalization and death. Molnupiravir was associated with a benefit for 30-day mortality, but not hospitalization, and further reductions in mortality in that 31 to 180 days was observed for both antivirals. Number 2, we've got remdesivir. Number 3, we just covered Molnupiravir a little bit. Convalescent plasma for a select group, the immunocompromised in the first few days. And yes, let's not do those harmful things. All right, moving on to that second week. Remember, we've all learned that the natural history of COVID for some folks is they're sick during the first week, they start to feel better, and then that second week we get that cytokine storm. Steroids we've talked about in those that meet criteria. Anticoagulation, we have guidelines, but are people following those guidelines? What are people doing? So we have the article, National Trends in Anticoagulation Therapy for COVID-19 Hospitalized Adults in the United States, analyses of the National COVID Cohort Collaborative published in JID. So here the investigators used the National COVID Cohort Collaborative and conducted a retrospective cohort study 2020 through 2022 to assess anticoagulation use patterns and identify factors associated with therapeutic anticoagulation. It's basically looking what have folks been doing. So among 162,842 hospitalized COVID-19 patients, 64% received anticoagulation, 24% received therapeutic anticoagulation. Now, the therapeutic anticoagulation use declined from 32% in 2020 to 12% in 2022, especially after December 2021. So what were the predictors for therapeutic anticoagulation? These included age, being male, non-Hispanic Black, obesity, increased length of stay, and invasive ventilation. Also, vaccination rate was associated with a lower use of therapeutic anticoagulation. So just to remind people of what are the guidelines and why maybe has this changed over time. The guidelines had recommended therapeutic full-dose anticoagulation in those floor general medical patients admitted during the second week with moderate to severe COVID. It actually recommended using prophylactic in the critical care settings where the risk of bleeding and other complications seemed to outweigh. And everything had been qualified with, use your clinical judgment, do an individual assessment of your patient when making these decisions. A couple of the things, as we're seeing here, is over time, we're actually seeing that maybe that risk-benefit calculation is shifting. So expect potentially some updated recommendations. Pulmonary support, remdesivir if we're early enough, maybe some immune modulation, tocilizumab, baricitinib, and remember, only using those antibiotics in those appropriate situations. And a bunch today on the late phase PASC long COVID. Part of this is also because, boy, did I get a lot of response to our discussion of the article last week, development of a definition of post-acute sequelae of SARS-CoV-2 infection published in JAMA. So a couple bullet points here. I'm going to leave in a link again. In this first analysis of data from the Recover adult cohort, criteria for identifying PASC based on self-reporting symptoms were delineated, and several distinctive PASC subtypes with varying impacts on well-being and physical health were described. The Recover adult cohort included SARS-CoV-2 infected and uninfected. Uninfected participants had no known history of SARS-CoV-2 infection, and index was defined as a past negative SARS-CoV-2 result date. There were some questions about whether or not folks were included that developed issues post-vaccine. And they say in the statistical analysis section, a rule for identifying PASC was derived. In the full cohort, 37 symptoms had frequency of 2.5% or greater, adjusted odds ratio 1.5 or greater for all 37. Now, using the full cohort, they identified 12 symptoms with corresponding scores ranging from 1 to 8. I've got a table 2, and the optimum PASC score threshold was 12 or greater. Now, a lot of people had issues with the concept of this this cutoff, this sort of binary you have or did not, and it's really interesting. I actually have up for Vincent and me to look at figure 2. You really see like, okay, yeah, there is a little bit of an inflection here when you use different cutoffs, and really what that inflection is related to is the uninfected being classified as having PASC, right? So when you're out at like 25, basically you're not pulling anyone, accidentally. 18, you're still kind of there. When you get up to about 12, you're starting to see about 3%. Even if you go down to, pick 8 here, because you got 8 and 8. So if you pick 8, about 8% of the time you might accidentally pull someone in who doesn't have post-acute sequelae of COVID. So a lot of limitations here, a lot of concerns that people had. So I wanted to just discuss those. So first, they do say that the proposed paradigm and accompanying decision rule require, and I love this, iterative refinement as additional data becomes available. Now, iterative refinement is not something that I use in common parlance. Basically, they're saying, yeah, we're going to have to use this for a while and kind of see. They also say PASC score provides an operational definition of PASC and requires further refinement and validation. Yes. Recover recruitment is ongoing, and not all the participants have reached the analysis stage. Evolution and refinement of phenotypes are anticipated as additional data becomes available. I think, Vincent, you made this point, like that they're only looking at this one point in time. What about 3 months? What about the 6 months? What about 9 months? What about evolution over time? Second, selection bias was likely among the post-acute cohort participants that may have affected the frequency estimates, including the distribution of the subphenotypes, because past severity may impact study participation. Third, I'm going to say uninfected participants may have had prior asymptomatic SARS-CoV-2 infections, just not detected. So that sort of weakens our discrimination characteristics. Fourth, symptoms were self-reported, and only some symptoms integrate severity scale. So participants could report other symptoms as free text, but these were not necessarily included in this analysis. Fifth, we have a number of confounders. And sixth, I'm going to say, and I think this is what got a lot of people upset, more than 200 symptoms of PASC have been reported, each with the potential of being life-altering and debilitating, and symptoms highlighted here within may not reflect the severity or the impact of those symptoms. It's a bit of a challenge. I was trying to figure out like who are the current activists for the long COVID community that can, there was a patient representative on this paper, but I'm not sure at this point who is sort of filling this vacuum and there to help this community. I think we're getting near the end. Just a couple more here. The article Neuroinflammation After COVID-19 with Persistent Depressive and Cognitive Symptoms was published in JAMA Psychiatry. And we may need some twin hosts this week in neurology to weigh in on this one. So here they are looking at persistent depressive symptoms post-COVID using PET scans. They reported higher activity in certain regions of the brain. I vaguely remember these: the dorsal putamen, the ventral striatum, the prefrontal cortex, the anterior cingulate cortex, and hippocampus. I'm glad I'm not going to have to answer any quiz about those afterwards, but they suggest evidence for an inflammatory change, elevated gliosis in the brain of individuals with COVID depressive cognitive symptoms. That's the COVID-DC. Gliosis, they say, may be subsequent to inflammation, injury, or both, particularly in the ventral striatum and dorsal putamen, which they say might explain some persistent depressive and cognitive symptoms, including slowed motor speed, low motivation or energy, anhedonia, after what in some cases is just a mild to moderate COVID-19 illness.
I wonder, Daniel, so inflammation is a big part of it, I'm sure. I wonder if anoxia at any point was also part of it, right?
I think that would be important to know, to sort of look at, and have that information. Because boy, not getting oxygen to your brain is not something you would expect to leave you without some chronic changes. So, all right. And a couple, I think I've got just two more articles, and then we're going to wrap it up. So the next article maybe is going to give us a little bit more insight into what we discussed from the Recover study. And so the article, Long COVID Clinical Phenotypes up to 6 months after infection identified by latent class analysis of self-reported symptoms, published in Open Forum Infectious Disease. So these are the results from a multi-center prospective study of symptomatic adults tested for SARS-CoV-2 with prospectively collected data on general symptoms and fatigue-related symptoms up to 6 months post-diagnosis, not just at 6 months, but up to 6 months. So these investigators identified symptomatically homogeneous groups among participants with COVID-19 and among others without COVID-19 at each time period for both general and fatigue-related symptoms. So among 5,963 baseline participants, 4,504 COVID positive, 1,459 COVID negative, 4,056 had 3-month and 6-month data at the time of analysis. So 4,056 had 3-month, 2,856 had 6-month. They identified 4 distinct phenotypes of post-COVID conditions at 3 and 6 months for both general and fatigue-related symptoms. And this, I think, is a big takeaway. There was substantial class switching over time. Oh my gosh. Those in one symptom class at 3 months were equally likely to remain or enter a new phenotype at 6 months. So I want to say that's really critical, right? So let me just mention the 4 subtypes: minimal or no symptoms, fatigue, headache, and muscle or joint aches without loss of smell or taste, fatigue, headache, and muscle or joint aches with loss of smell or taste, multiple miscellaneous symptoms. And I think this is really key because what was suggested from the Recover analysis is, now we've defined our 4 phenotypes, and now we can try specific things with each phenotype. But what if people are bouncing around from phenotype to phenotype? That's going to impact our study design. So I think this is important to consider. And the last, and I think this is an ongoing issue, the article Coronary Microvascular Health in Symptomatic Patients with Prior COVID-19 Infection, an updated analysis published in the European Heart Journal Cardiovascular Imaging. Here I'm going to, I wish I could phone a friend. I think we need a This Week in Radiology or This Week in Cardiology. We've got a few cardiology friends out there, right, Vincent?
Yeah, we do.
But basically, they're looking at the microvascular health of the heart post-COVID using PET scans. Now, cases consisted of patients with previous COVID-19 who had clinically indicated positron emission tomography, PET imaging, and were matched 1 to 3 on clinical and cardiovascular risk factors to controls having no prior infection. Myocardial flow reserve, MFR, was calculated, and comparisons between cases and controls were made for the odds and prevalence of having impaired MFR. So they're using a cutoff of less than 2. The median interquartile range number of days between COVID-19 and infection and PET imaging was 174 with 53 through 338. Patients with prior COVID-19 had a statistically significant higher odds of impaired myocardial flow reserve, less than 2. Adjusted odds ratio of that, 3.1. So 3 times as likely to have impaired myocardial flow reserve, get a p-value of less than 0.001. Now, the results were similar in clinically meaningful subgroups, a bunch of subgroups, and the proportion of cases with this MFR less than 2 peaked. Are you ready for this? 6 to 9 months from imaging with a statistically non-significant downward trend afterwards, comparable across the variants, but increased with increasing severity of infection. All right, so I will wrap up here with, as I've been saying, no one is safe until everyone is safe. Let's continue to spread the knowledge. I do want everyone to pause the recording right here. Go to parasiteswithoutborders.com and click donate, even a small amount. Every bit helps us continue our work. And we are now in the middle of our Foundation International Medical Relief of Children fundraiser. So May, June, and July, donations made to PWB will be doubled up to a potential donation of $20,000 for FEMRIC.
Time for your questions for Daniel. You can send them to daniel@microbe.tv. Had a question last night on the live stream, Daniel. Someone wanted to know, do Queens and Nassau County hospitals have the 3-day outpatient remdesivir infusion?
So in our local area, actually, the Catholics have stepped up and done this, and actually some of the Northwell hospitals as well. So yes, actually, we do in the local area.
All right. Carol writes, I've tweeted that there's no adverse effect of mRNA vaccines that isn't also a result of COVID infection, and that with COVID infections, it's almost always worse, but I'm not 100% sure that's completely accurate. What do you say?
That's an interesting comparison. I mean, it's probably true, but I want to sort of add the nuance here. So, like we just talked about cardiac damage, right? And we talked about how after COVID, significant number of people have cardiac issues, and then we talked about that rare but identified risk that particularly peaks in adolescent males. Might be a slightly different mechanism. So, some might take issue and say, well, it's a slightly different phenomenon. Guillain-Barré, I think we see that much more often with COVID infection than we do with vaccines. This is an interesting way of putting it. And I think in general, it's true. Much, much safer to get vaccinated than to get COVID. Fewer issues with vaccinations, but we have identified, unfortunately, some.
Can you also discuss the claim that mRNA vaccines are causing turbo cancer? Cancer is one of the diseases I don't see being caused by mRNA vaccines, but is caused by some viruses. My understanding is that the recent increase in cancer diagnosis following a decline because people were avoiding being screened from fear of getting COVID and hospitals being overrun with COVID patients.
Yeah, no, I would suggest that's in line with misinformation. I don't think there's any compelling evidence. And boy, we have looked. It's not an absence of looking for a connection with the mRNA vaccines and cancer. Like I remember a few people who are I remember one prominent person who's no longer with us. That by now everyone who had been vaccinated would be dead. We're still here. We're doing well. Actually, better off than folks that did not get vaccinated before they got infected. So no, I don't think this cancer scare is based on anything solid.
FF writes, sometime in June, it'll be 6 months after my second dose of Novavax. I'm trying to make a decision about whether it's worth getting a Novavax booster then 6 months after the previous two, or whether I should wait until the fall for an updated Novavax vaccine. Does it make sense to get a booster in June, or will this not be effective towards current variants? I live in New York City, had COVID once, took Paxlovid. I'm very concerned about getting infected, as I've heard people getting long COVID after their second infection, and my first appears to already have caused some issues for me with memory.
Yeah, I mean, this is a very timely question. As we just discussed, Novavax has decided to, and has already started to produce an updated XBB variant. Be reassured, as we've discussed many times, T cells will save us all. It does look like there is a durable, ongoing protection against severe disease that we get from the prior doses. And it probably makes sense at this point to look at that XBB vaccination in the fall, hopefully getting those neutralizing antibodies, hopefully getting that 3 to 4 month reduction and even getting infected and all the benefits that come with that.
Jason writes, when the show opened for TWiV 1012, you made a comment that a lot of COVID deaths are now silent. People are dying in facilities. Decisions are being made just to make them comfortable. The question I have is, I would like to see more comment on how do deaths in facilities not get counted as COVID deaths? Does this mean physicians don't put COVID on the death certificate and write something else? Does it mean COVID is not tested for? What does all this mean in terms of hiding deaths caused by COVID, and why would this be done?
Yeah, I wouldn't think of it as hiding deaths. I would think of it as not seeing them, right? So, physician goes to the hospital and sees their patients. They're not seeing these individuals. These individuals are not coming into the outpatient practice. These individuals are staying, they're dying at home or they're dying in the facility. So they're not being hidden. They are being counted. They are being identified as COVID deaths. But as we talked about with the air pollution, right? Yesterday, it looked like you were in some movie, maybe Blade Runner came to mind for me, where everyone's like, this looks so horrible, and the masks went on. Today, the air quality was still bad. It was about half as severe, still in the orange and red in many zones. But you didn't see it. It didn't have that reality for people. So the masks were right back off until your eyes started burning and you started coughing. So I think that's the challenge here. These are not being hidden. They are being counted. But there's an emotional response to seeing somebody in the ICU on a ventilator. There's an emotional response to seeing the isolation rooms in the hospital. And these people are dying quietly. They're dying in hopefully a better, more respectful, more dignified manner, but it's not on the news. There aren't these trucks, refrigerator trucks in front of hospitals or anything anymore.
Ryan writes, have you seen any evidence about risk to existing aortic aneurysms from COVID infection? I've read a couple of published studies presenting anecdotes suggesting dissections have occurred from infections.
Yeah, be careful. As I've been saying for a while, anecdotes the plural of anecdotes is not data. There is some endothelial aspect to an acute COVID infection, some sort of endothelial activation. I am not sure there's, any clear significant, but yeah, if you get COVID and all the inflammation that goes on and the stress, would I be concerned about someone? Would I consider this a high risk condition? I would say yes.
And Christine writes, as I sit here taking Paxlovid for my first case of COVID, now that I'm retired, I have time to get out and get myself a case of COVID. I'm reading about the nitric oxide nasal spray being sold in Israel, Europe, and parts of Southeast Asia called Enovid. You see one study in J Infection, August, that reports it lowered viral load in the nose and throat. Subject showed faster symptom resolution. They discussed possible decreased transmission. You know any reason why this hasn't been studied more in this country? Do you think it would be harmless enough to try if one were to buy it in Israel?
So this falls into that category of interesting, promising, and I've seen those curves, and there aren't any copy numbers, so let's make sure we use the right terminology here. And it did look, and it did, stay statistically significant as far as the separation. I don't know clinically, and I think that's where we are right now. The goal of the FDA, the goal of a lot of physicians in the U.S. is to do no harm. And so the whole idea of, it's, let's just try it. I think we talked about the SSRI deaths, where maybe we actually increased the number of people that died by throwing SSRIs. Hydroxychloroquine probably increased the number of people who died, and certainly saw a number of people like aspirate on their own vomit because of the GI upset it induced. So yeah, I am not a huge fan of just trying stuff until we really understand the safety profile and the benefit that comes with that.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.